It's very appropriate to bring up the opportunity to consider a palliative consult either inpatient or outpatient. We also have outpatient palliative facilities. Now, as an outpatient, again, you're going to a clinic, you're seeing a doctor, there'll be medication adjustments. Sometimes the difference with palliative is that we think outside of the box a little bit. We use the same tools that most doctors use, but maybe we're using them slightly differently. The other thing that you might see in palliative medicine is the lack of a fear regarding these. You know, physicians are very strongly monitored for their use of narcotic substances, and I think that many physicians are somewhat fearsome of that surveillance. But more importantly, they're afraid of what these medicines might do to the patient. They might narcotize them, might suppress their breathing. A little bit of that is lack of education. Very rarely will narcotic medicines used appropriately in the outpatient setting cause a great deal of problems. Sometimes in the inpatient setting, there is a little bit of an overshoot, but almost always that is very, very closely controlled, very closely monitored, and depends upon what the patient wants. There are some very interesting ways of delivering medicines these days. One is called PCA, patient-controlled analgesia, where the patient defines how much analgesia or pain control they need. This cannot be done, though, in a person who is comatose or obtunded or not with it. They won't know to press their little button. Medicine can be delivered orally. It can be delivered in the gum line, which is very interesting. You know, cocaine users and tobacco chewers have known that you can deliver psychoactive substances in through the mucous membranes for about probably 4,000 to 6,000 years. But we're just getting around to it in medicine. So you can deliver medicine through the gum line, through the mucous membranes. There are some medication delivery systems that are cream-based. There are patches. There's a lot out there that a lot of general physicians might not be familiar with. So although I say they would have somewhat of an understanding, that's where the difference comes in, that palliative really does think outside the box. We have a couple of tricks we use. In the inpatient setting, I will tell you, the strongest ally for the palliative team is the nurse. The nurse sees that the patient remains uncomfortable. The nurse sees that the patient is in distress or the family is in distress, and very often will put the bug in the ear of the physician to consult palliative medicine. Most of medicine runs like a great big army. You know, the captain of the ship is the captain of the ship. That's the attending physician in the field that entered the patient into admission. And then any extra help that doctor wants, he requests a consult, usually with the permission of or upon the sentiment of the family. Families can ask for it. The nurse usually is the one that acts as the intermediary, but you can ask the doctor yourself. That's not a problem. Most doctors will not be opposed to it. When a palliative physician is asked to be on board, what that really means to the family is it doesn't mean we're stopping things. It means we're changing things. We're shifting the goals from something that we don't think we can fix anyway to something that we think we can manage and guarantee, which is largely comfort, safety, hygiene, dignity, support. Those are the things that are in our tool bag when we can't fix something. And allowing us to be part of that is a privilege. We understand that. We understand that that's a very, very important part of a person's life, and being allowed to be in that is a privilege. But allow us. We went to school. We all of our palliative care specialists, our nurse practitioners, our nurses, our case managers, all want to do that. We don't want the patient to die. We want the patient to live as long as they can, symptom-free, the best way they know, because that's the best way we know.